and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm the proud mom of a preemie 28-weeker Tessa, and I'm also a former journalist. And I'm honored to be your host here today from Halifax, Nova Scotia, and thank you for joining us. Preemie Chats is brought to you by Canadian Premature Babies Foundation, or CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. Whether you're a parent, a healthcare professional, researcher, or someone interested in understanding more about preterm birth, you're in the right place. Together, we're building a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. Be sure to visit our website. It's up there on the screen, canadianpreemies.org, and there you'll find helpful resources, our latest projects, and most importantly, a community of people who want to see our little ones thrive. If you're watching live today, please join the conversation. Share your questions and comments in the chat, and we'll address them during the program. If you're watching a recorded session, you can still connect with us through the website below. It's through meaningful discussions like this that we advance, practice, and grow together. Let us know where you're watching from. We would love to hear from you. Now, today's topic has a ripple effect through all of our preemie parent community. We're looking at securing your own oxygen mask first, parent well-being after newborn adversity. I know when my preemie was born, all of my energy and strength went into getting my 28-weeker healthy and home. Today, we're going to be hearing from Dr. Eyal Cohen and Dr. Joel Ray as they share with us what we know about parent health outcomes after newborn adversity, including the birth of a preterm child, and what can be done to improve these outcomes. Dr. Eyal Cohen co-founded the Complex Care Program in the Division of Pediatric Medicine at the Hospital for Sick Children, where he is program head of child health evaluative sciences in the Research Institute. He is a professor of pediatrics and co-executive director of the Leong Center for Healthy Children at the University of Toronto, with cross appointments in the Institute of Health Policy, Management, and Evaluation. And joining him will be Dr. Joel Ray. Dr. Ray is currently a clinician-scientist at St. Michael's Hospital and professor in the Department of Medicine and Institute of Health Policy, Management, and Evaluation at the University of Toronto. Dr. Ray's clinical specialties are obstetrical medicine and internal medicine, and his research interests include maternal and fetal health, diabetes and pregnancy, and ethnicity and pregnancy outcomes. Thank you both for joining us here today. We have been having a bit of technical difficulty, and so we may just be joined by Dr. Ray with just his audio, but we're happy to have them both here to share your presentation.
Thank you, Leah. I'll begin the presentation and then hand off to Dr. Ray. Just a couple of extra introductions about me. I wear a pediatrician hat in this conversation, and thinking about parent health is very important to the work I do, but is not how I am trained. I'm trained to look after little people, but over the course of my career have increasingly appreciated how important it is to think about the little people's caregivers in their lives, and have learned so much from parental caregivers and also from colleagues of mine on how we can do this better, including Dr. Ray, who you'll hear from afterwards, who looks after big people in his clinical career. So the title that we used for this conversation today is Securing Your Own Oxygen Mask First, Parent Wellbeing After Newborn Adversity. And I'm going to open with where this comes from for those of you who've never heard this before. If anyone's ever flown on an airplane and looked in the seat pocket in front of them, this is actually a real seat pocket picture that I took a number of years ago. You've seen something like this, which basically says that if there is turbulence or some other issue during a flight and the oxygen masks come down, to make sure that you put the masks on your child before you put the masks on yourself. And that is, to many parents, not the easiest thing to do. Because we instinctively want to do everything we can to help our children in every circumstances. And I'm also a father of 3 children, one of whom was born prematurely, and distinctly remember my own personal experiences and those of my partner at the time when our daughter was in the NICU for a very long time, how difficult it was to think at all about even why we should be bothering to put oxygen on ourselves, because we were so fixated on the health and well-being and the worries we had about the health and well-being of our child. But just like in the airplane scenario, if we do not care for ourselves, the obvious implications are that will create challenges in caring for our children. And that's easier said than done. And hopefully over the course of this conversation, we can think a little bit about, again, reemphasizing why it's important, and also what sort of strategies, given that our instincts are sometimes not to think about our own well-being in the context of an extremely ill preterm child, what we can do to mitigate some of the effects of that on our own health and well-being. So the first point I want to make, and I only have about 8 or 9 slides, is that one of the things that is almost universal in experiences I've seen of parents of infants who are preterm in the NICU or in the time after the NICU is that the experience is extraordinarily profound. And to an observer who sees it from the outside, it can sometimes be very different than what people who are actually living it at that time are. And the notion that it doesn't have a huge impact on us is sometimes lost, right? And I love this quote: the expectation that we can be immersed in suffering and loss daily and be untouched by it is as unrealistic as expecting to be able to walk through water without getting wet. And that is true both of an experience within the NICU, and the details of this figure aren't that important. They just get at this idea of all these kind of stressors that occur over the course of a NICU stay with a preterm baby, before admission, at the time of delivery, and all the hills and valleys of a course within the NICU. There's progression, then there are setbacks, and then a whole bunch of really, really stressful transitions, going home, possibly moving to another hospital. And unfortunately, in some circumstances, for some parents, loss and bereavement that occur for some families. That's within the NICU. The work I do clinically is in leading care of children who have complex care needs after they leave the NICU, in the community and throughout their lives. Not all children, but many children who are born preterm have challenges that don't disappear at the time of discharge from the NICU. And over the course of their lives, many need services in different places from many different providers over time. And the experience that many of them have, and apologies for the font changes, it's, I think, just the formatting using this presentation mode, is an extremely stressful one. And this is a diagrammatic representation of a typical kind of child that I follow in my clinic, who has all sorts of different health issues, needs to see lots of different doctors, nurses, and other healthcare providers in many different hospitals, clinics, developmental centers over time. And that experience of, recurrently having to interface with the healthcare system, with the developmental system, with the social services systems, is extraordinarily stressful. The analogy I sometimes use is the one of air travel. If you fly one time a year on an airplane and you have to deal with a delay of a flight and, all the annoyance of air travel, it's not that big a deal. But if you have to fly every single day on an airplane, all these little things, the delays, security, mechanical issues, et cetera, that inevitably arise on many, many different flights, that becomes almost intolerable. So if you take that and add to that the layer that we're actually talking about someone we love and care for so deeply, you can imagine how stressful existence of care can be for many parents. And we know that this kind of stress, this recurrent stress, particularly when it's associated with the need for prolonged caregiving, is associated with a lot of adverse outcomes. And I'm just going to list some of them here. I already mentioned stress, and the effect of stress has biological implications on our bodies. It affects our hormone secretion in our body. It affects a lot of our metabolism, and leads to mental health and physical health outcomes that are problematic. Sleep deprivation, anxiety, depression, and there's evidence even of premature cardiovascular disease, and even for some individuals, premature mortality. Now, I want to make a really important point. This evidence is on the level of a population. It doesn't mean that every one of us who experiences stress from caregiving for a child will experience these things. The vast majority of people live healthy, active, happy lives, but this risk is present when you experience chronic stress from caregiving. So it's very important to at least recognize that and think about ways of mitigating this risk as much as possible, with the understanding that there are lots of things that can be done to prevent these sorts of outcomes. So I want to just quickly talk about a concept of what we call post-traumatic stress disorder. So for anyone who's not familiar with post-traumatic stress disorder, it's actually a psychiatric diagnosis, and the diagnosis is less relevant than the concept here. And it's originally been described around people who experience horrible things, war, abuse, those sorts of things in early childhood. And the idea is they experience a very horrible traumatic event, and then over the course of their lives, that experience creates a fear of that threat that's almost pervasive, and triggers of that fear creates a whole bunch of different intrinsic phenomena that can be very challenging. Reliving the episode, feeling avoidance, and it's all kind of anchored in the way our brains are wired. We are all wired in what we call the fight or flight response, right? When something, wherever we came from evolutionarily in the savannah, when we were being chased by, thousands of years ago, being chased by a predator of some sort, our brains are wired to know that when there is danger, we run away, right? That's the fear is not always a maladaptive response. Fear is actually, in many ways, a good thing. If we didn't have it, we would, we wouldn't be able to function in the world. The problem is when you feel that kind of wired, that fight or flight response all the time, that's when PTSD kind of kicks in, because it occurs even in situations where there isn't a threat at that particular period of time. And to give a very real example of things, I often see parents in my clinic who've experienced, a really traumatic experience in the NICU 10 years ago, and they still remember, things from that NICU episodes. For instance, if they had a bad interaction with a doctor of some sort. I've had parents say to me, when I smell cologne that's similar to what I smelled that day, that gets me kind of, really, really worked up and stressed. So sometimes it's not even the event that triggers the response. It's something associated with that event. And the and the idea of what we can do to deal with this is to recognize when we are in states, when we've experienced trauma, that are maladaptive. And there are two kinds of ones to kind of grossly simplify this. One is that we are too aroused, right? We enter a situation where our past experience causes us to be emotionally distressed, feel like we can't think clearly. We call that hyperarousal. And there's another response that we sometimes have, which is we just disengage. We feel depressed, lethargic, unmotivated. And I can't, in a very short period of time, talk about all the strategies that can be used to overcome this. Dr. Ray will talk about a few things that are helpful, but essentially, one kind of kernel I'd like to pass on is the idea of recognizing within ourselves when we're in our optimal state, when we can be engaged, is really, really important. And if we've experienced these sort of really traumatic, stressful events in our lives, to understand when we're in these hyperarousal or hyperarousal states. And there are lots of examples of people and resources that can be supportive in helping individuals understand on their own level how to enter that window of tolerance. And I work in a healthcare organization that is starting to understand this more and more. These concepts I'm talking about are not new. What I think is changed in the delivery of care in NICU, in neonatal follow-up, and in care in child health in general is being more and more aware that many families experience trauma, and we need to be more aware of trauma and provide trauma-informed care. And in a nutshell, what that means, and I'll tell you as a clinician, that's challenging. I find it challenging to do sometimes. When I engage with a family that, for whatever reason, has experienced trauma, their response to interactions historically has been us responding to them as, "What's wrong with you? Why are you so angry? Why are you so withdrawn?" Right? Trauma-informed care says that is a completely unhelpful heuristic, a completely unhelpful way of approaching a problem or an interaction with another human being. We have to move from what is wrong with you to what actually happened with you. And that involves these steps of trauma-informed care, making sure we're in a physically and emotionally safe environment. And that's like ensuring conversations are private and in a safe space, providing trustworthiness and transparency with clear, appropriate messaging to families. A lot of work on peer support, and I know that this incredible foundation does a ton of that work with families of preemies. Much work on collaboration and mutuality, empowerment, providing skills for parents and families so that their voices can be heard and participate more actively in conversations around care. And lastly, and very importantly, being really, really aware of historical, cultural, gender, racial, and other structural barriers to providing person-centered care. And in the organization I work at in Toronto, we're starting to slowly move in a direction where we start incorporating more and more thinking about how we can better support caregivers as an organization. Understanding, again, that opening slide of mine, if our aim and our mission is to improve the lives of children, we cannot do it without being attuned to the health and well-being of the caregivers who provide care for children. And without going into great detail of this last slide, essentially, it has to take a whole system approach. We have to provide parent supports early on, and this foundation, again, does a ton of amazing work in that space. Clinicians have to recognize when families are experiencing trauma and distress and provide them with appropriate resources and support. So we're trialing in the complex care program at Sick Kids this stepped care model where we have social workers who can provide support to families who are identified because we screen universally for supports, and those who have really, really severe presentations actually having a pathway to provide them adult psychiatric support for the very small minority of patients who need that level of support. Most we can provide support via our program and their family physician and primary care providers. But really the idea is to incorporate positively oriented thinking around how we can best support caregiver mental health and well-being to maximize the quality of life of not just their children, but also the caregivers and families themselves. So I'm going to pass on to Joel now.
Thanks a lot, Eyal, and glad you can. Yes.
Sorry to interrupt you there. I'm wondering if you wouldn't mind trying to join from your phone so that we could see if we could see you. And in the meantime, we could take some questions.
I have a flip phone.
Oh, okay. Sorry, I thought you did the prep on your phone with Fabiana, but that's okay. We'll carry on like this and get to hear your presentation at least.
No problem. And actually, I was going to say it's fortunate that you cannot see me. The audience stands to benefit, and I'll not comment on Dr. Cohen at all. The presentation you just heard is great, and I'll try to keep up with that. When I see usually sick mothers, either while pregnant or having given birth, many of those mothers and the accompanying partner will have had a preterm birth event. And so I often engage with those women who themselves are sick while also dealing with a sick newborn or a premature newborn who might even be in another hospital. And I can only empathize with the amount of complexity that's put in front of one or both parents at the time that they're dealing with possibly not only their precious newborn, but also a health ailment immediately present, in addition to all of the psychological stress. So next slide, please. What I'm going to try to do is that's great. Is just to try to prevent some evidence about hope. And this is really about the parents, and it's about the evidence that interventions, not particularly complex interventions, can help diminish the parenting stress that, as Dr. Cohen said, can both be experienced immediately but have clear-cut lingering effects weeks or years later after the original birthing and preterm infant experience. Next slide, please. So in this meta-analysis, and I want to show you evidence because I'm trying to be respectful of the intelligence of this audience, and I'll try to just show you in crisp terms some of this evidence. So in this meta-analysis, what they wanted to do was to identify how early intervention programs could reduce parenting stress in those parents who had a preterm baby. And in this summary, which is already a little bit of an outdated review of published papers, they had 10 randomized clinical trials, 1,683 parents in total, which is not actually a lot for what's considered a randomized clinical trial. And what they did is they typically, in the studies that were included, had parents who were given the standardized mother-infant, what was called transaction program, or MITP, and then another intervention that was being evaluated, what was called the NIDCAP. And these are methods to help out the parents. And these are two different kinds of interventions, and they were each typically compared to a no intervention arm. And then the outcomes they looked at were child care related stress for the parents, personal discomfort, and then total stress for the parents. And they usually measured that using a standardized tool called the Parenting Stress Index, or PSI. So they're trying to say, is one of these two kinds of intervention programs better than nothing. Next slide, please. And so when they included preterm births, they were typically at about 30 weeks gestation. So they're the real deal for prematurity. They're not at the margin of 36 or 37 week births, but these are the ones where the babies are going to be in the NICU for a pretty long period of time, and the parents will have an enduring amount of stress with recurrent care and visits inside the NICU environment. And in summary, they showed that there was a significant difference in favor of the EI program groups, both when they assessed those parents at 18 months and even up to 5 years of after the birth had occurred, supporting Dr. Cohen's point that there is a lingering PTSD-like effect that can occur, and that these programs, when the intervention is early enough, can make a difference for the parent or parents in what we'll call the long-term landscape. Next slide, please. In this study, which was published just last year and wasn't included in that review I showed you, they looked at a home-based program for actually post-discharge parents, again with preterm infants. And if you could go to the next slide, please. So they set out an aim to ask, does a home-based post-discharge early intervention program reduce parental stress in families with, again, the real deal preterm infants of early prematurity? And my comment about real deal is not that a 34-week preterm birth isn't consequential, stressful, or otherwise. It's more that these earlier preterm births have a lingering constancy to them and a higher risk of adversity for the newborn when they're earlier. So it was a randomized clinical trial, and they compared home-based early interventions with 37 families against the so-called standard care. And they randomized the families to get one or the other type of arm of intervention or no intervention. It's not a big trial, but these are hard trials to do. Next slide, please. And so the early intervention was a workshop that's created that teaches the parents 3 strategies to apply to their infant. So it's a way of bonding at home after discharge, 3 things that aid the parents in managing what they now have as their child at home. There's both hearing and vision induced training for them to strategize how to do that with their newborn. Whole body massage of the infant, which no doubt for the infant must be extremely pleasant. And for the parent, once they learn how to do it, a very loving, tactile interaction with their child. And then social training with kangaroo care and what they called hearing vision integrated training. So I won't get into those details, and they're beyond my technical skills as a clinician to describe properly. Next slide. And so 60 days after the intervention, they went back to the parents and they said, let's look at your total stress scores. And they had in the outcomes lower parental distress and lower scores in dysfunction or difficulty interacting between the parent and child. And so at 60 days at least, there was a difference. Once they got to 6 months of age, the total stress scores were actually similar in the 2 groups. So this didn't look like it had a lingering effect. But again, it's a smaller trial. In the short term at the 60-day, there was a benefit. Next slide, please. And then this is, again, a last year study. So these are the very recent ones. And you can just read the title. I'll let you read it for a moment and then describe it. And if you could go to the next slide, please. So they wanted to evaluate the impact of on maternal stress of a family integrated care program for preterm infants who are actually, in this case, still in hospital. And a family integrated care program encourages parents to care for their infants on the ward or in the ward as the primary caregivers. Now, that may, for some of the parents on this um, today, may be familiar, and for others unfamiliar, but there's been a real movement towards, in general pediatrics and in neonatal care, pushing the parents to feel comfortable providing the care and really being integrated in a way that gives them confidence that they can see what's going on. But naturally, it also encourages physical bonding and the role of the parent as the steward for their child's uh, growth during the in-hospital period. This was a bigger trial with about 300 newborns in the family integrated care program and about 300 in the standard care. That's a really decent accomplishment. And next slide, please. And so they did show for the primary outcome, which was what was called the parental stress scale, at the time that the baby is being discharged from the hospital, that's reduced. And it was definitely significant in that score reduction. And they argued again that the statistical value, which is very significant, also was reflected in a clinically important reduction in stress, and argue that this sort of implementable program is valuable and worthy of most hospital care systems considering it. Next slide. And this is an overall impression that both Dr. Cohen and I have really just shared with you. It's very summative. The consideration for how much stress occurs for the parents and families of preterm infants is undoubtedly high, and that the optimistic angle here is that reduction in that stress is achievable both in hospital through various means that are implementable and after the baby has been discharged home with the parent or parents. I'll now pass it back to the others. Thank you.
Thank you so much for your presentation. I do have some questions here, and hopefully some come in from those watching as well. Some very valuable information shared there, so thank you both. My first question is on, you were talking about the family integrated care practice while families are in NICU, which I was a part of the family integrated care study in 2013. So I'm very familiar with that, and how that helps decrease stress. And then we talked about the home and very similar kind of caregiving habits, I guess I'll call them, also help reduce stress. But is it something that should be done in collaboration, or is it, if you didn't get to be hands-on in NICU, then this is kind of something that can help? Or how do those two experiences work together, or do they?
Well, I'll comment briefly. It is the right of parents to be fully involved in the care of their premature or term infant. And that right just has to be managed by firstly making the parents very comfortable with the unforeseen situation that they're placed in, because it wasn't planned that premature birth was going to be the case. So many are in shock, but getting them out of shock is a necessary first step. And then bringing them into constant care or intermittent care is the strategy of the social worker, nurse practitioners, and neonatologist pediatricians in that environment. And it's best done with a very explicit program or set of steps described. Keeping things implicit is impossible for a very in shock or very traumatized pair of parents. There's absolutely no reason that what occurs around many times with a lot of technical things like a ventilator, special lighting, nasogastric feeding, some of those technical things need to be left out of the equation, like ventilator management. But many of the other facets of the child care that are going to be taught in the NICU can be continued at home. But once at home, there are further developmental components that, from the hearing and vision, need to be expanded upon. I'm not sure that a 25-week-old infant is going to benefit from vision or hearing interventions that early. So there's a stepward expansion of what makes sense. But I see it, from what I understand, as a continuous, explicit set of steps that are best done in a programmatic way, starting with the parent's comfort and then scheduling and then full involvement in childcare. Eyal, do you have something that might make more sense than what I just said?
I've had the privilege of seeing the evolution of FICare to be, oh my God, they're doing something different. I think it was Estonia where it was first looked at, to now how in the world are we not doing? And I still don't know if is it universally across Canada now? I think it's moving in that direction, and it should be. Again, on a high level, the less we can pathologize parenting and what parents have the right to do and what we are biologically programmed to do, the better outcomes are for us as parents. And what is amazing of the data that you presented and from the trials that we're conducting in Canada as well is, holy cow, the better the outcomes for the babies too, right? So in my career, I actually think it is one of the most revolutionary things that I've seen. Yeah, there are many bad things are going on in healthcare. I'm not going to pretend it's perfect, but this notion that we now understand that involving families in care as much as is feasibly possible is optimal for so many good reasons. Is really important. I still think when we get to the nitty-gritty, decision making, like all sorts of parts of healthcare, we're still not perfect at it. But on a high level, the more engaged you are in a productive way as a parent in your child's care, the better your health is, and the better your child's health is.
And I loved what you said there, Joel, about it being explicit as well, because I think, something that happens so often when we're in NICU as families is that we wait for permission, and that isn't explicitly given. And sometimes we don't have kind of that natural response that is expected of parents to have when they have a healthy term baby. Fabiana has a question here as well. She said, how do we take all this information and advocate for all families to have access to mental health support in the NICU and in the community?
Maybe I'll start with, because it's a pretty wicked question, Fabiana. And I also, second question, I see also your comment in the box about advocating to make FICare standard everywhere in Canada. The answer is everything possible. Some of you are involved, I would hope, in local family advisory networks and patient family advisory committees within either NICUs or hospitals. It's not easy work. Can be traumatizing. It takes a lot of time, and sometimes you're not listened to. But it's very important to go into those sorts of conversations, the few windows you have where someone might be listening to advocate for things you think really matter. And I do think, FICare as a concept and mental health supports as a program are both essential in any NICU and community-based setting where NICU graduates live. So that would be one approach. The other the other approaches are health authorities. Some of you are in different provinces or jurisdictions where there are other decision-making bodies that decide what gets funded, what doesn't get funded. I'll tell you from my lens as a pediatrician working in a freestanding children's hospital. Again, a nice thing I've seen in my career has been a little bit of a shift in thinking, oh, we only look after kids, we only look after kids, we only look after kids. Why do we even need a parent strategy? And now we actually do have, a center for a whole center built to support caregivers in my organization, or at least to think about how to better support caregivers in my organization. So, and that, that's a bit of a philosophical thing about, what's our fiduciary duty as a children's hospital to parent and family well-being. But again, if you come back to I think the point we both been trying to make over this is like, you can't look after babies without looking after parents. And parents also have a right for their own health and well-being. And they're not going to leave the bedside of their preterm baby to go to their family doctor, which could be 100, 200 kilometers away from the hospital. No one's going to do that because our instinct as parents to be with our baby. So all of those sorts of things, I think, take pushing from every angle at the level of clinicians, at the level of programs, the level of hospitals, and sometimes even at the level of ministries and other sorts of payers of healthcare to remember that you can't design neonatal and child health systems without thinking about the health and well-being of parents and caregivers.
Joel, do you have anything to add there?
My quick comment is that stress on parents who have a preterm baby will never be eliminated, because that's an impossible thing to eliminate given the existential nature of where they're at. I can't think of anything more important, also having 3 kids, than those births and the moments and days surrounding that birth, each of the births. And so you cannot eliminate the stress of a preterm baby on the parents. My hope is that FICare and some of what Fabiana is correctly aiming towards is by making it standard and available before we even think about mental health access for the parents, that FICare will help to reduce that stress at its source, which is the very interaction with the infant, newborn, and the satisfaction of knowing that they're involved and that the infant newborn is in their hands and the hands of other good care providers. The complexity of access to a mental health care provider in those days and weeks that provides care for the parents is a little bit complicated. I love the possibilities, but I can imagine that in many parts of the US, Canada, and elsewhere, there is a clear separation of where the baby is and where the parents are going to be from the adult care provision, a mental or physical health provision. And so I have a feeling that most parents will drop the ball on themselves and focus on their child. And if the interventions that optimize the parental experience with the child lead to improvements, the parents will still come out better. I still appreciate the critical nature of a social worker in the NICU who enhances beyond the parenting care, the well-being of the parents, paying for parking, possibly being 100 kilometers away from their home, figuring out how to even pay their hydro bill at home while they're sitting in a hospital 100 kilometers away. So the social worker, at a minimum, to me, remains one of those great undervalued assets inside hospital environments.
Thanks for that. And I think, even on top of and aside from maybe the mental health and the stress aspect, I I know for myself, even physically, you're supposed to go for a 6-week check postpartum, and I didn't. And so I ended up bleeding for more than 60 days and had extreme swelling. And a lot of parents have this same story of, like you said, we're looking after our kids. A lot of us are in crisis mode, trying to get through. And so we just don't have the time or space to look after ourselves, whether that's our emotional and mental well-being or our physical well-being as well.
Yeah, I mean, I really appreciate that point, and so does Eyal. We spend an enormous amount of time worrying about, even in the first week or two after giving birth, and the woman who has given birth is not in hospital anymore. She's barely able to get to the NICU because she's so unwell. How does she access a caregiver if she's in a hospital that isn't where she gave birth even? And that's a common scenario in Canada and the US. And that separation of hospitals makes it really tough for her to get care, especially if her baby is solely in a pediatric hospital where there is no adult care. And that gap, I think it kind of freaks us out and makes us very concerned about what's going to help her with her bleeding, her mastitis, her blood pressure, her infection, and whatever other mental health malady that's arising. And we haven't, mea culpa for both of us, we haven't optimized the resolution of that. We spent a lot of time talking about it, but this gives us onus to seriously reconsider or fully further consider that common scenario for the parent. And I'm only talking about the birthing mom. There's another parent, they may be enduring immense stress. They're not out of but they generally won't have vaginal bleeding as the other parent. It's the birthing mom who's going to be the immediate focus.
Mm-hmm. We do have another question here from Genevieve. She said, can you speak to ways to optimize the experience and impact of family integrated care for parents who have different roles? For example, moms versus dads, parents who have to continue to work and can't be present and involved in the care as much, and ways they can still benefit or have their stress reduced while their baby is in NICU.
So first of all, thanks for joining, Genevieve. I know Genevieve, and I've heard that your baby's doing okay. So thank you for joining, and I know how difficult time you're going through, and thanks for your question as well. You're asking a really, really important question, and I didn't talk about this in great detail. About gender differences in some of the outcomes I spoke about, in gender differences in caregiving roles. I've been doing research on caregiving for the last 15 years, and I have to say, when I ask parents to fill a questionnaire about how they're doing, not in different sex families, 90% of the time it's the mother who fills it up, almost consistently. So. And the few studies we know about fathers or other non-birthing parents seem to indicate that some of these effects, these health effects, may be smaller on them, in part because for reasons that they are able to be employed or have other outlets that may mitigate caregiving stress. But we don't really know, and no one's really looked at it in great detail. It's actually something we're interested in understanding a little bit better. I think on a practical level, the idea of, wherever possible, bringing in other caregivers, and I would even add siblings who into care in a developmentally appropriate way for the siblings and for the non-birthing parent. In a way that's feasible is really, really important, both for family dynamic reasons, and also because there may be stressors that are difficult to that don't come out, that are sometimes hidden, when that individual isn't at the bedside as much as the other parent are. So I think as much as possible, doing whatever can be done to engage other caregivers and use it's called FICARE. It's not called my care. It's not mother, right? It's about the family and thinking about the entire family dynamic is where this evidence comes from. So and I think good NICUs that are running things like FICARE are attentive to that. Joel, do you want to add anything?
No, I think you said it succinctly and clearly.
You're kind of creating a troop here online, people wanting to get involved in the work you're doing. So is there a way that families who are watching can be involved in some way of moving your work forward?
Yeah, for sure. I mean, let me and Fabiana chat offline after this, because we actually are doing putting in some research grants in which we can totally use family advisors in that work, and when there are policy opportunities for some of this stuff, for sure. There are other societies and foundations that do really, really good work. I partner a lot with a center called the Canadian Centre for Caregiving Excellence, which is trying to work to create new policies to improve caregiver well-being. Historically, that's been focused on other kinds of caregivers, not caregivers of premature babies, but caregivers of primarily our aging population. But this is certainly within scope of the work they do, and they're very, very engaged with policymakers federally and in multiple provinces and territories. So those kind of are two that immediately come to mind. But I think after this talk, we'll take some time to think about other opportunities for this incredible community to support moving forward in improving the kind of things that families deserve.
And I can even think of something out loud, if I may. The idea of asking the parents who have been connected to this group, many of them reflecting maybe months or years earlier, on whether or not the mom was sick or not at the time that she gave birth, to continue that idea, to ask whether she was separated by hospital from her baby, a different hospital, because often the preemies get sent to another place, yes or no, and to try to gauge ways of that mom would have preferred a bridge to be better created, and then separately to try to ask the other parent, if there is one, what they think, because they were watching that other parent, potentially a sick mother and a sick newborn, or premature newborn at least, either in the same hospital but two different parts of the hospital, or at completely different hospitals. And that other partner gets a real different dose of stress by having two loved ones in two different places with two different sorts of problems entirely. And holy smoke, that can be stressful. And we know nothing about the narrative experience of those mom and, I'll put in quotes, dads, but the other parent, and what they think. And we could probably, if Fabiana agrees and Eyal agrees, we could probably get a pretty straightforward set of questions out to try to better understand in a narrative fashion what they thought or experienced.
If I could just add one more thing, and ask maybe of the group, if anyone wants to write in the chat box, like, what do you think we can do? All of us sit in different chairs at different tables. What would be the one thing you would like to see change from your experiences that would have supported you as a caregiver or your partner or the rest of your family better in the experience?
I love this discussion. I am going to thank you both for joining us, and hopefully people will leave their comments, please, as both Eyal and Joel were saying, we need many voices at this table. And so reach out to Canadian Premature Babies Foundation if you want to be involved. It sounds like something is in the works here, so that's great. And yes, Fabiana saying, be proactive. And so she also mentioned EPIC, the evidence-based practice for improving quality. That conference is happening next month in Montreal. And so CPBF will be there. We will have families there, healthcare professionals, and we'll be talking about this very thing, advocating for FICARE to be in NICUs across Canada, for there to be a standard. And we'll be looking at collecting data on parental engagement and outcomes. So everybody stay tuned on this very important topic. And thank you, Eyal and Joel, for joining us here today and for sharing your wisdom and knowledge with us.
Thank you, Leah.
Thank you, Leah, and thank you to all the participants. Really enjoyed it.
And I also want to mention one of the things that was spoken about in that presentation, the tenets of trauma-informed care, was peer support. And so I'd like you to just be reminded that we do have a peer support group that meets every Thursday at 12 p.m. Eastern time. It's drop-in, it's casual, it's on Zoom, and it's a chance to connect with others who understand the NICU journey. And so I'm going to be putting in the link in the chat. And if that's something, whether you're recently out of NICU, whether you're currently in NICU, or even if you have an older child, I'd encourage you to join this peer support group and just be with people who get it and have been in NICU. Thank you all for joining us for this edition of Preemie Chats. These kind of conversations are so important to have. And it's just, I think the more voices we have at the table for you being here, learning together, being all on the same page, it's so important for pushing this advocacy forward. So thank you so much for joining us. If you missed part of today's session or you want to revisit it, just head on over to our website, canadianpreemies.org. There you'll see all of our past episodes. It's also available on our YouTube channel. And while you're there, you can explore the many resources and support options that we offer to help families on their journey. As a charitable organization, CPBF relies on the generous support of people like you. Your donation allows us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. Thank you for being a part of this community. We will see you next Friday at 1 p.m. Eastern Time for another live episode of Preemie Chats.